So what we do is we have a monthly clinic, as Farah just alluded to. We book them ourselves, so if anybody wants us to see a patient, they have to email us. Because of the limited resources, we can't see everybody who's just got cardiac disease or palpitations. We vet those referrals and decide who we need to see and who we don't need to see. So that limits the numbers a little bit. And then we sit in the room together.
Around what percentage with your heart association 3 and 4? Because we do get a lot, not a lot, but really
quite a few of ours are NYHA class 3 and 4. Most of them are class 1 and 2.
So in complex middle heart disease, do you use SPE prophylaxis in university all cases, or how do you do that? Because endocarditis is also a problem at our end.
Yeah, we do. I don't recall a case of active infective endocarditis in a pregnant woman in our clinic.
What protocol do you use for SPE prophylaxis? Endocarditis prophylaxis.
I'm not sure I understand what SPE prophylaxis is.
So it's a standard protocol, Halima. We don't have anything changed. It's almost the same. We don't see too many cases, to be honest. Therefore, Anna looked slightly surprised. Because of the different, progress in time.
What kind of cases do you get in your setup over there?
We have a lot of cases with congenital heart condition, and we manage a lot of mitral stenosis, regurgitation. Recently, we have seen a lot of patients with hearts.
We do have Anna's slides put up, so
Perfect.
Okay, well let's start quickly then. Can I advance my own slides? That'd be brilliant.
Ask her the way she did, you please try that.
She doesn't have the option yet.
I don't have that option yet.
You just indicate so that. Should we move?
Yes,
You
please.
can say next, and then we can move from our side.
Okay. Next slide. We've already talked about quite a few of those things. Next slide, please. So when we talk about patients, pregnant patients with heart disease, we have to consider 3 groups. Next slide, please. All right. Those 3 groups are, first of all, those with pregnancy-related heart disease, i.e. those who have heart disease as a direct consequence of the pregnancy, such as peripartum cardiomyopathy or spontaneous coronary artery dissection. They are quite rare. The second group are those with known pre-existing heart disease, and they are, technically they should be the most easy to manage because we know about them before they even get pregnant, so we should have had an opportunity to preconception counsel them and be prepared for their care at every step of the way. But the vast majority, in our case, and I have seen from the data that were presented in the session before, are those that are unmasked by the pregnancy itself. They're either undiagnosed or undisclosed from what I've just heard, and these women decompensate as a result of the pregnancy. Next slide, please. Previous slide, please. So these patients, those highlighted in blue, are the ones who present to the obstetricians first, and I think that's why they are of particular importance to the audience, I hope. Because the other ones, those with known pre-existing heart disease, will have been seen by their family doctor, the cardiologists beforehand. But these ones I've just highlighted there are the ones that present to your practice unannounced or announced. Next slide, please. Pregnancy-related heart disease is rare but important, and there needs to be a level of suspicion. And I've listed 4 conditions there that I can think of that are directly related to the pregnancy. Next slide, please. Pre-existing heart disease unmasked by pregnancy is rather common, both your end but also our end, because we have in the area where Farah and I work, We have a lot of patients with pre-existing valve disease that, for example, rheumatic valve disease, just like you do, who are well compensated in the non-pregnant state, and they decompensate when they fall pregnant. And the things that we see, just like you, are cardiomyopathy, valve disease, particularly rheumatic, pulmonary hypertension, essential but most likely secondary to things like severe mitral stenosis. And they typically present early in the pregnancy, and the reason for that, you can see on the next slide, please. I've just put those two diagrams there to remind ourselves what happens in terms of cardiovascular adaptive physiological changes in the pregnancy. You can see that cardiac output and intravascular volume expansion happen very early on in the pregnancy, which is why they tend to present rather earlier than later. Next slide, please. Those with pre-existing heart disease, I don't want to go into much detail, but ideally they should have been looked after by the cardiologists, and the family doctors should have had some preconception counselling, but we all know that the reality is often very different, both at your end, but also ours. They may have been lost to follow-up, they may have no awareness that they should be seeing a cardiologist prior to falling pregnant. There may be language barriers, there may be cultural barriers, for example, as you've explained to us earlier, cultural barriers of disclosing heart disease, but also perhaps that not having a child is not an option. Access to healthcare can be difficult, or access to the relevant specialists also. Next slide, please. So when we do look after these patients, we can enter that pathway at any point. Next slide, please. Okay, yeah, that's it. So the care that we deliver to these women should be multidisciplinary at all stages, and I haven't got much time to go into details, but you can see here that it should all start with good risk assessment prior to pregnancy, adjustment of medication to facilitate safe pregnancy, then reassessment at any stage wherever appropriate in the pregnancy, and good delivery planning, and that includes where does she deliver, when can she deliver in the spoke, or does she need to go to the hub where all specialties are available, how should she deliver, can she go to term, or does she need to be delivered early, for example, and where does she go after the delivery? Who needs to be around? Do we need a neonatologist, for example, if the baby's very premature, and so forth. And then also, once she's given birth, that may be our only opportunity